Okay, here we go. So we're going to talk a little bit about what is strangulation, why should we care about it, the anatomy of strangulation, getting a history on strangulation, the exam, and then finally we'll talk a little bit about imaging in strangulation. So why do we care about strangulation? So beyond the actual initial presentation, it's really important to think about strangulation in a broader context. So in the context of an intimate partner violence relationship, strangulation increases the risk of attempted or completed homicide by many times. If you look through the data, it's really anywhere between 4 times, 7 times, 10 times. But really, for our purposes, all you need to remember is that it increases it exponentially. And so it's something that we need to think about when we see these patients in the emergency department. What exactly is strangulation? So strangulation is applying something externally to compress the structures in the neck. It can be done manually, 1 hand, 2 hands around the neck. It can be done with another part of the body, a chokehold or carotid sleeper restraint. It can be with a ligature, meaning with a wire, a cord, a piece of cloth, anything that is pulled tightly around the neck, or it can be done by hanging. Obviously, with hanging, it's more common in attempted suicide than interpersonal violence. So what structures are we concerned about when a patient comes in with non-fatal strangulation? Primarily, we're looking at the jugular veins, the carotid arteries, and the airway. So the trachea, the tracheal rings, the cricoid cartilage, the thyroid cartilage. Those are the main structures that we're concerned with. And over time, a kind of theory of how death from strangulation occurs has developed. And the thought is that most likely to cause death is going to be compression of the jugular veins. That's because they're very superficial, they're easily compressed. It only takes about 4.5 pounds of pressure to compress the jugular vein. So then when that's compressed, that leads to congestion of blood in the brain and eventual loss of consciousness, cerebral hypoxia, and then death. Second, most likely is going to be compression of the carotid arteries. It takes a little bit more pressure to actually compress the carotid arteries, anywhere from 5 to 22 pounds of pressure. And obviously that's going to cut off flow to the brain, causing cerebral hypoxia and then death. Much less likely is going to be actual compression of the airway. So to compress the trachea, it takes about 33 pounds of pressure, so significantly more than compression of any of the vasculature. And to actually fracture the cricoid cartilage, it takes about 45 pounds of pressure. So it's really most likely that you're going to be looking at vascular compression when patients come in after non-fatal strangulation. And then finally, the other thing that we can think about is the carotid bodies. It is possible that when strangulated in just the right place, the carotid bodies can be stimulated, thus causing a cardiac arrhythmia and leading to loss of consciousness, cerebral hypoxia, and death. So now that we get the anatomy, what are we going to talk to our patient about when they come into the emergency department? Obviously, ABCs initially. But I think that it's useful to think about getting the history and the review of systems in a very kind of anatomic way, considering all of the anatomic structures that can be affected. So did they lose consciousness? From pretty horrible studies that happened in the 1940s out in Minnesota. Thanks, Gina. These studies were conducted on prisoners and psychiatric patients, studying basically, they had a device that strangulated patients, and they were able to show, loss of consciousness happens at about 10 seconds. So from these studies, if we have someone who says, yes, I lost consciousness, we can say there was probably significant amount of force that was applied for at least 5 to 10 seconds. Additionally, did they have incontinence? In the study in Minnesota, there was some patients that had incontinence before loss of consciousness, some that had it after. It also can be a fear response. So it's something to ask your patients. They may not recognize that they did lose consciousness, but they may have urinated, and that may be a clue that something else is going on. Do they have any new weakness or numbness? So this is important because maybe the strangulation was not applied for long enough for the person to lose consciousness, but it did cause blunt trauma to the vasculature. So you're worried about thrombosis, you're worried about dissection, carotid dissection, vertebral artery dissection, and you're worried about, did you knock loose an embolism that caused an embolic stroke? So these are really important questions to ask. Finally, do they have difficulty breathing or difficulty swallowing? Obviously, this is assessing more of the airway. And primarily, you're looking at the trachea, the larynx. Do you need to get ENT to scope them? And then another thing to think about also is post-obstructive pulmonary edema, which can actually occur after the strangulation is released. So we've got our history. Now we're going to examine our patient. This chart that's up on the screen right now is actually from a study that was done in 2001 of 300 strangulation cases that were referred for prosecution in San Diego. Of those 300 cases, a whole 50% of them had absolutely no physical findings. So I think from this study we can take that it's really important to actually ask the patient. They may not recognize how dangerous strangulation can be. They may not mention it. So, asking your patients who are status post any type of assault, asking your patients in police custody, was anything placed on your neck? Were you choked? Those are going to be really important questions. And once you get an affirmative that yes, they were strangulated, what are you actually looking for on a physical exam? So there's going to be some obvious signs. If it's ligature or bruising around the neck, or someone who's in severe respiratory distress, those are going to be pretty obvious. But some of the things that are going to be more subtle are going to be looking for petechia. So particularly in darker skinned individuals, it's going to be difficult to discern petechia if you're not looking for it. So you want to look around the eyes, you want to look at the conjunctiva, so you want to really look under the lid and see the conjunctiva. Is there petechia there? Look in the oropharynx for petechia. You want to also listen to their voice. Do they sound like they're hoarse? Do they sound like they're whispering? Ask them, does their voice sound how it usually sounds to them? You also want to look for subcutaneous emphysema, which may indicate that there's violation of the airway to some extent. And just looking for small abrasions that you may have otherwise missed. So we've done our exam, we've got our history. What's the next step? Your next step is going to be wondering, are we going to image this patient or not? And I'm going to tell you, I don't have an answer for you for most of your patients. There's really poor data to guide management in this respect. So this study that's up on the screen right now is a retrospective review of 142 patients that are status post non-fatal strangulation and had imaging performed in the emergency department. Of the 142 patients that were scanned, only 2.1% ended up having vascular injury radiographically. And that 2.1% of positive findings is compared to 2.8% of false positives. So meaning that there were patients that initially were deemed to have vascular injury, and then it was later reviewed by a neuroradiologist who said, actually, this is not. So very, very low likelihood of finding an actual injury in this population, at least. Another study that's actually just coming into print now, you may have heard if you listened to MRAP this month, they talked a little bit about it, published in Annals, is a retrospective analysis of about 350 patients who are status post non-fatal strangulation. But importantly, there are 328 patients who are status post manual strangulation. These patients came into the emergency department awake, alert, and just over half of them received imaging in the emergency department. Of those patients, only 5 had radiographic injury. And of those 5 injuries, only 2 were really clinically significant. One was a carotid dissection and one was a vertebral artery dissection. Both were observed and discharged on aspirin. So again, really, really, really low likelihood of finding something. And these are really 2 of the most recent studies that describe it. There's really not good evidence for what to do. But there is a body that provides some guidance, at least. This right here, and I don't want you to try to read through it. I'm just putting it up here so you know you can Google it if you want to. This is actually from the Strangulation Training Institute, and they have a guideline on how to evaluate patients who are status post non-fatal strangulation in the emergency department. So I've simplified it here. The guideline from the Strangulation Training Institute says that you're going to image anyone who reports loss of consciousness, anyone who reports vision or hearing changes, anyone who reports anyone who has any physical findings, anyone who has any neurologic signs or symptoms, anyone with dyspnea, and anyone with any subcutaneous emphysema. Those are all going to get imaging, and CTA is going to be your go-to because it's going to give you your best bang for the buck. On the other hand, the only folks that you're not going to image are the folks who have absolutely no signs, absolutely no symptoms, absolutely no exam findings, and they have a reliable home monitor, meaning there's someone who can be with them for the next 24 to 48 hours and keep an eye on them. Then those folks you don't have to image. So, by this guideline, I think it's a great attempt to try to provide something for emergency department management. However, it is it leans towards imaging pretty much everybody. The ASAP has put out in their ebook of managing sexual assault patients, they have a chapter on strangulation. And they say that, a middle ground is sometimes going to be observation, which seems reasonable. If you're, to watch them, maybe you don't want to image them, see how they do for 48 hours, and maybe they can be discharged home. Finally, I just want to reinforce, like I said at the beginning, that strangulation, it's not always something that we think of as, a horrible event or even a sentinel event, but it really can be, particularly in the setting of intimate partner relationships. So I put this phone number up here not because I want you to remember it or put it in your phone. This is the phone number for the National Domestic Violence Hotline. It's because I want you to think when you have these patients, if they are in a partner violence relationship, to get resources on board, get social work if there's 24-hour social work wherever you happen to be working. If there isn't, take 5 minutes if you have it to do a little bit of safety planning if they're returning home. And if you're not comfortable doing that, which I think is completely fine because we are jack of a million trades and we don't have to be a master of this, just Google your local domestic violence hotline, give them a quiet place and a phone if they want to chat, and that person can do some safety planning. Just think about the increased risk of lethality with these folks. So in summary, think about your anatomy. Do an anatomy-based history, anatomy-based review of systems. Ask your patients, particularly in police custody or status post any kind of assault. And really think about your imaging. Again, there's not great data to guide you. But you can always pull up the algorithm from the Strangulation Training Institute if you want something to back up your decision. And then finally, just remember the increased risk of homicide in patients who are strangled in the setting of an intimate partner relationship. And those are my sources.